It's 4 p.m. Assalamu alaikum wa barakatuh. Welcome to this session that will be presented by the group of Pediatric Saudi group of Pediatric Ophthalmology and Strabismus. I will leave you with the president of the group, Dr. Hashem Al Marzouki.
Thank you, Dr. Mohammed. On behalf of the Saudi Ophthalmology Society and the Saudi Pediatric Group, we are truly honored to be here today, and I would like to take this opportunity to thank the Egyptian Ophthalmology Society for their kind invitation. I mean, this valuable partnership is exactly what we are looking for, and it should help us in elevating the subspecialty and help our patient, inshallah. It's our great pleasure to share this session with Dr. Mohammed, the Vice President of the group. During this session, we'll discuss and present challenging cases in pediatric ophthalmology. The presenters will share their experience and insights, and we'll be looking for an open discussion to enrich the experience for everyone, inshallah. Our first talk gonna be about surgical management of complex iris and pupillary disorder. Will be presented by Dr. Ismail AlGhamdi. Dr. Ismail Dr. Ismail is a consultant pediatric ophthalmology and strabismus, an anterior segment surgeon. He's a board member of Saudi Ophthalmology Society and consultant in pediatric ophthalmology and anterior segment at King Saud Medical City in Riyadh. He's also had a consultant position at several leading tertiary institutions in Saudi Arabia and previously served as a head of eye unit at King Khalid University Hospital. Dr. Al-Ghamdi has contributed to major ophthalmology textbooks, including Duane Ophthalmology and Curbside Consultation in Pediatric Ophthalmology, and has received multiple Best Teacher Award, most recently in 2025. Dr. Ismail.
Bismillah ar-Rahman ar-Rahim. Assalamu alaikum wa rahmatullahi wa barakatuh. It's my pleasure to present today a few cases that I'm sure most of you will face it in practice of pediatric ophthalmology. The first case, or the first two cases, I did face a challenge because both of them, they were having pinpoint pupils. And they were in the first weeks of their life. So as you know, the most important thing here is to have a clear visual axis to prevent amblyopia. The first case was we were facing difficulty in medically dilating the pupil. So at 4 weeks of gestation, I took this child to theater because the pupil is pinpoint. And as you can see from the picture, there is a membrane surrounding the pupil, only leaving a small eyelet inferiorly. So the decision I took is to go superiorly. As you can see in the video, I did bridal suture to control the eye because I was sitting superiorly. Then because of I was afraid of conj ballooning, so I did conj berectomy. After conj berectomy, I did limbal incision for two purposes. First one, because I want to be peripheral as much. If I need to do peripheral iridotomy, it will be easy for me. And the second thing, because I want to close the sutures and cover it with conj at the end. Then I use the viscoelastic material for two things: to maintain the stability of the anterior chamber and to use it as a way to separate between the iris and the anterior lens surface without risking the clarity of the lens. After several attempts, I was able to open this small eyelet inferiorly, and I was able to elevate the iris from the surface, anterior surface of the lens capsule. After I opened and I was able to find a small area, we go back to the video, I used vitrectomy machine, but in the dry setting. So I entered with a vitrectomy machine, as you can see, without the sleeve, so only vitrectomy dry, and I opened, I increased the size of the pupil. Then after I was sure that it will accommodate the size of the vitrectomy machine, I entered with coaxial vitrectomy. I draw the pupil inferiorly without risking the clarity of the lens. And at the end of the procedure, the pupil size was adequate for the child, and I was following this child. He is around 8 years now, and his best corrected visual acuity is 20/25 with minimal astigmatism. This is not always the case, because the same scenario was in another patient, but this patient was having a more difficult situation because, and this is the technique, I did the same. And as you can see from this video, I was not able to separate between the iris and the lens. So I used my peripheral incision for BI. But as you can see, it was very adherent. So I was not able to inject viscoelastic to elevate the iris from the lens surface. At this point, I did use mechanical force to separate between the iris and the lens at the pupil side. So I used Sinskey hook and Coughlin hooks to dilate the pupil. But I found that the lens is cataractous. So at this point, my decision was to go, and after I did adequate opening for the vitrectomy machine, I entered with vitrectomy, and I opened the anterior capsule. I removed the lens, and I left this child aphakic. But our aim is to have a clear visual axis, and this is what we achieved in this case. The three other cases that I will share with you today is the cases of iridodialysis. And this is, you will face it after blunt trauma. Sometimes you will see cases of iris dialysis, and you will think, what would you do? In one case, the lens was clear. So we have a challenge to do iridoplasty and maintain the clarity of the lens. So I will share with you the video of how would you do it. As you can see in the video, the iris dialysis is more than 12 hours. So the first thing I did is conjunctivotomy against the area of at the site of the dialysis. And then I opened incision opposite to the dialysis. I used viscoelastic material to separate between the iris and the lens. And I did open paracentesis. Through the paracentesis, I will use Coughlin hook. This Coughlin hook will help me prevent touching the lens through the long Brolin needles. The long Brolin needles, as you can see, I folded the edge of the iris so I can pass the needle through. Then I use the straight needles. I pass it carefully, not to touch the lens. How I did it? I used curved needle holder, and I used the Sinskey hook as a support. You can see I'm using the curve of the Coughlin hook, and I'm using the surface of the iris, and I'm trying to push, not touching the lens, maintaining the clarity of the lens. And at the end of the procedure, you will see that we achieved a good result, and the pupil was round, and I closed the conjunctiva over the suture after burying the suture. This situation will be easier if you have cataract lens, but you will be in a situation, which step you will do first? Would you remove the lens first or suture the iris first? It depends on the situation of the iris. If the iris is more than 12 hours, like in this case, and there is vitreous, I prefer to go and remove the vitreous, suture the iris, then remove the lens. And this is what we did. We did anterior vitrectomy by manual, then we did the same steps. But you will be more relaxed here because the lens is cataractous, so it's not a big issue if you touch the lens or you open the anterior capsule. At the end of the procedure, we were able to put the IOL in the bag, and the pupil was in a good situation after we sutured it. The other case, the situation of the iris was not bad as the previous one. So I said, now I will remove the lens, then I will suture the iris. As you can see in the video, the dialysis is not much. It's from here to here. It's not clear in the video, but you will see it later. I did incision, then I released the synecha between the iris and the anterior lens capsule using viscoelastic material. Then I used iris hooks to dilate the pupil, open the anterior capsule, remove the lens material, put IOL in the bag. Then I removed the iris hooks, and I opened conjunctivotomy again using the straight Brolin needles, double arm. I sutured the iris in place, and at the end of the procedure, you can see that the pupil was in good size, and good sight, and the IOL in place. So surgical peers and key lessons always aim to preserve or restore normal anatomy, maintain anterior chamber stability throughout the procedure. Viscoelastic is your most reliable ally. Use it generously. Protect the corneal endothelium and lens capsule whenever possible, and every moment should serve something. As a pediatric ophthalmologist, the most important reward for us is the feelings of your patients, and it's the most truthful and most enjoyable moments if you receive nice words or nice letters from your patients. These are copies of 2 patients. Thank you.
Thank you, Dr. Ismail, for the great talk. Even though the surgery itself looked easy, we know how difficult it is performing this surgery. But the outcome was great, achieving 20/25 vision in one of the patients. Actually, this is our ultimate goal. So thank you, Dr. Ismail. By the way, Dr. Ismail did 2 fellowships, one in cornea and one in pediatric, and he chose pediatric at the end, right? Our next talk, Dr. Mohammed Al Shamrani. It isn't always straightforward. Dr. Mohammed Al Shamrani is a consultant pediatric ophthalmology and uveitis and clinical assistant professor and director of pediatric ophthalmology fellowship at King Saud University Medical City. He is the vice president of Saudi Pediatric Ophthalmology Strabismus Group. Dr. Shamrani holds Saudi Board of Ophthalmology and KKH Fellowship in Pediatric Ophthalmology and Strabismus. And also, he had a master degree in executive administration. Before joining King Saud, he worked as a consultant of pediatric ophthalmology and uveitis and chair of the pediatric ophthalmology department at King Khalid Eye Specialist Hospital. Dr. Mohammed.
Thank you, Dr. Hisham. It's an honor to present on behalf of our group in this prestigious meeting. Thank you for your listening to us. I choose to present this title because usually difficult cases, you will sort more and try to look for them. But always, as the Arabic saying, من هيئة الحذر, the danger comes from the area that you are least expect. So this was an 8 years old healthy girl. She's using glasses for 2 years. Right eye minus 10.5 with minus 3.5 axis 10, and left eye minus 9.5 with minus 2 axis 160. Her family are concerned about progression of myopia and having high myopia. She's studying in second grade in school with good performance, and there is no family history of high myopia or other childhood occurred disease. In examination, her vision was 20/60 with her current correction. There is no shift. Her media is clear retinoscopy. And cyclic refraction, it became more myopic, minus 12.5 with minus 4 cylinder right eye and minus 11 with minus 2.5 left eye. So this is with the myopia boom that we are seeing now, and knowing that the myopia is increasing prevalence. In 2020, about a third of population, they are myopic. Expected to be 50th population, the earth will be myopic by 2050. And about in 2020, 4% population, they have high myopia, more than minus 6. So it's a routine case that we are always seeing in the clinic, and all of us are managing them. But we look to the fundus as part of the examination and usually look for if there's peripheral myopic change that needs some treatment. It was normal fundus. And she has mild cupping, about 0.6 to 0.7. IB was 28. So what's happening? There is something wrong. I don't have slit-lamp photos for her, but you can see here from the IOL master that we did for her to calculate the IOL power. Her axial length was within normal, so it was not axial myopia. The AC depth is only 1.4 in the right eye and 1.65 in the left eye. The normal anterior chamber depth at this age should be around 3.57. Her lens, we know that the crystalline lens is the part of the body that keep growing throughout life in anterior posterior diameter. Her lens thickness was 4.7 in the right eye and 4.8 in the left eye. So this is the, if and when the patient reached 80 years, the lens diameter, anterior posterior diameter will be about 4.8. So this is large lens with shallow AC. So she's having spherophakia that can be easily missed if somebody did not take care of the appearance of the fundus. So we know that spherophakia is reduced in the equatorial diameter if there is macrospherophakia. There's increased anterior posterior diameter, the increased convexity of the lens, and increased power of the lens. Sequences of this one, patient will have high lenticular myopia, the anterior chamber will be shallow, and the IOP may be elevated. It is rare condition, usually bilateral, present in childhood. It can be part of systemic diseases, or it can be an isolated condition. Some syndromes that not associated with spherophakia or microspherophakia, like Wilmer-Cassani syndrome, Marfan syndrome, the news are stretched, homocystinuria, some of these syndromes. Other genetic causes like LTPB2, which can be mistaken as primary congenital glaucoma, best child present in the first few months of age with high IOP. Somebody will think it's primary congenital glaucoma, while actually it is due to lens subluxation. Fibrillin 1 gene mutation, and can be isolated. If we have such a case, the usual management, you observe the patient. If there is myopia is accepted, there is no high IOP. If the you can do peripheral iridectomy to decrease the IOP. If the lens is very thick, high lenticular myopia, glaucoma, then you have to remove the lens and then rehabilitate the patient with either putting sclerosing IOL, glued IOL, or put IOL in the bag if it can accommodate it. So we'll get back to our patient. We get glaucoma consultation. They advise to go for lens removal. So I did for her lens aspiration with posterior chamber IOL implantation in both eyes. 3 months post-operatively, the eye was quiet, cornea is clear, both eyes, anterior chamber is deep, and IOL in place. Her refraction was plus 0.5 right eye with minus 2.75, axis 180, and minus 1.25, minus 2.25 left eye at 170, and 20-25 both eyes. And IOP was controlled out medication. 3 years post-surgery, we did for her before YAG capsulotomy during the course of her follow-up. She's 11 years of age now. Her vision is 20/30 both eyes. IOP is 20 and 18. No medication. We are keeping following her for the IOP. She's wearing glasses with low stigmatism. She has clear cornea both eyes, deep AC, IOL in position with good size posterior capsulotomy. And her retina is flat and the cupping stabilized at 0.6. Thank you.
Thank you, Dr. Mohammed, for the great session. Usually, I think in atypical cases, we always should question ourselves again about the diagnosis.
Now we have Dr. Saif Al Obaisi, who present a topic entitled Anterior Segment Dysgenesis and Non-Recordable Visual Evoked Potential. Do we operate? Dr. Saif Al Obaisi, he is Pediatric Ophthalmology consultant at King Abdullah Specialized Children Hospital, National Guard in Riyadh. He's the head of Pediatric Ophthalmology Fellowship Program and head of Pediatric Ophthalmology Committee in Saudi Council Commission for Health Specialties. He's a member of the Saudi Board Exam Committee since 2022, and he's a regular examiner in Saudi Board and Fellowship exams. Dr. Saif.
Assalamu alaikum wa rahmatullah. It's a great honor for me to be presenting in this excellent symposium and very informative. My talk, the first talk will be talking about anterior segment dysgenesis and non-recordable visual evoked potential. Do we operate or not? First, I'll go quickly about the condition of anterior segment dysgenesis, which is also known as anterior segment developmental anomalies, are rare but potentially visually devastating. It's important for the pediatric ophthalmologist to be aware of the causes, evaluation, and treatment of these conditions. However, their etiology is just as important because associated extraocular conditions may need to be treated, and the family may need counseling for future pregnancies. First, as a consideration for of their in terms of their embryologic origin, it's divided into neurological crest cell origin, ectodermal origin, global origin. And the neural crest cell origin, there are some famous conditions like posterior endotoxin, Axenfeld-Rieger, congenital hereditary endothelial dystrophy, CHID, primary congenital glaucoma, eye syndrome. And in the ectodermal origin, limbal dermoid, corneal dermoid. And the last one, global origin, megalocornea, microcornea, aniridia, Bater anomaly, cornea plana, sclerocornea, and others. An unrecordable visual evoked potential in the context of anterior segment dysgenesis indicates a profound visual pathway dysfunction, often resulting from severe long-standing complications like uncontrolled secondary glaucoma or opaque dense corneal anomalies like severe sclerocornea. An unrecordable visual evoked potential implies that the visual cortex is not receiving or processing signals from the eye, reflecting a guarded or poor visual prognosis. This is an example of a patient with non-recordable visual evoked potential. And these are the patterns or the types of visual evoked potential: flash VEB, pattern VEB, and pattern onset offset VEB. Clinical drivers of non-recordable VEB in anterior segment dysgenesis are as following: secondary glaucoma and optic nerve damage with elevated intraocular pressure. Common anterior segment dysgenesis can cause severe optic nerve cupping. Second, severe corneal opacities like dense, white, or non-transparent cornea like sclerocornea. Optic nerve aplasia or hypoplasia. While rare, severe developmental failure of the optic nerve can coexist, leading to a complete absence of signals. And finally, retinal detachment and severe amblyopia. It can occur as a complications of previous surgeries or arising from surgical complication for the disease itself. Visual evoked potential finding and the interpretations. Flash VEB used when media, cornea, or lens is too opaque for the pattern stimulation. An unrecordable visual evoked potential indicates a severe damage to the retina or entire optic pathway. Prognostic value: an unrecordable visual evoked potential strongly correlates with a little or no light perception, particularly in preverbal children with a complex anterior segment defects. We have a case example which was published. Reported case in the International Medical Case Reports Journal from Kingdom of Saudi Arabia in 2023. It was from Ophthalmology Department, Dhahran Eye Hospital. In this report, they described a case of 4-year-old female patient who demonstrated its distinctive ocular manifestations at birth, namely a large and opaque cornea. We'll see the picture in the next slide. The pregnancy was uneventful and there was no family history of any significant congenital anomaly. The diagnosis of bilateral sclerocornea, aniridia, aphakia, and secondary glaucoma was established clinically. This is a picture of the patient before the surgery. In the picture A, examination under anesthesia of the patient showing evidence of sclerocornea, aniridia, and aphakia at the age of 2 weeks. And the picture B, presentation of the patient with sclerocornea, aniridia, and aphakia at age 4 years, but that was for the right eye, which was not operated. B-scan image to confirm the diagnosis of aphakia and the presence of sclerocornea, and it's clear that there was no shadow for the lens. Then early assessment, visual evoked potential was very poor visual potential. Primary medical therapy was failed to control intraocular pressure. So the decision at that time was to proceed with the cyclophotocoagulation both eyes, chosen as least invasive option. This is a quick description of flash VEB, as we mentioned that it is the most appropriate VEB to be used in these situations. So it's evaluated by examining the peak-to-peak amplitude between negative wave near 75 and positive wave near 100 milliseconds. So we can see it's very clear here. A significant decrease in flash VEB is defined as a decrease in the peak-to-peak distance between N75 and B100 by at least 50% from the reference amplitude. And this is another example of the non-recordable VEB. So we'll go back to our patient at 6 months. Vision assessment not reliable. Visual focus potential repeated, confirmed poor prognosis for our patient. Objective evidence of limited visual potential. So option discussed, penetrated keratoplasty, and the indication was clear cornea. This is just, and it's not the same patient. So family were counseled and guarded prognosis were delivered to them, high surgical risk and uncertain visual gain. VEB provided the only objective guide in non-verbal child, held frame expectations and highlighted mismatch between anatomical surgery and functional outcome. At this stage, we had a technically operable eye, but functionally VEB was already telling us the story. BKB at 6 months were performed, initially successful, persistent increase in intraocular pressure, necessitated another intervention of Ahmed valve, so it was also implanted, and ended up in a complication of endophthalmitis 6 weeks after surgery. This is also another simulating picture, not the same patient. Total retinal detachment happened after that, and then final outcome, no light perception, evisceration for the same eye, which was the left eye. So the fellow eye strategy, high surgical risk recognized early, surgery withheld in the right eye, management was only medical by medications, and B-scan showed flat retina optic disc covering. So very poor visual potential on VEB, objective assessment in non-verbal child, confirmed limited benefits from suggestive surgery, guided decision toward conservative management. And this is a final message from me. So despite technically successful surgery, the outcome was devastating. Visual focus potential helped to repeat the same mistake. So the lesson learned, objective assessment with visual evoked potential is crucial in eyes with poor visual potential. It can prevent unnecessary surgery and avoid devastating outcome. Thank you.
Thank you, Saif. You can proceed with the second presentation about residual exotropia. You can proceed with the second presentation.
Yeah. My next talk will be also about residual exotropia. Okay. So as an introduction, as a refreshment for the residual exotropia, residual and recurrent exotropia are a frequent long-term result after surgical intervention for these cases. And to differentiate between them, residual exotropia refers to the persistent angle of exotropia observed during the early postoperative phase, immediate or 1 week or 1 month. Residual and recurrent exotropia are common long-term outcome. Residual exotropia is the remaining angle, as we mentioned. Recurrent is a major long-term issue after surgery, for example, more than 6 months. So that means an improvement in the angle of deviation and then recurrence after 6 months. The residual exotropia in early postoperative period is strongly associated with a higher risk of recurrence. So how to approach those patients? As we know that sometimes the patient will come without enough information to clarify what was the previous surgery. So we have to take an important and full history. So in the history, you have to ask about this information. So when was the previous surgery? This is very important because it can differentiate between an early residual or recurring exotropia from the old surgery, which also can implicate a consecutive rather than residual exotropia. And also you need to know the number of previous surgery to decide whether a patient has a resistant condition and whether he will benefit, or to also evaluate the success rate for the patient. And also you need to know the operated eyes, types of deviation before the first surgery, if the patient can tell you about it. Immediate, you can also ask the patient, was it immediately seen after the surgery, or it takes time? As we mentioned, that residual and recurrence differ from each other. Also, you have to ask the patient about any medical reports, old photos, types of refractive error before the surgery, because it may indicate some types of deviation if the patient is hyperopic or myopic. Also, in the history, you have to ask about the course of the deviation after the surgery. Was it stable or was progressive, which may suggest consecutive deviation and slippage of the muscle. Also, you have to ask about intermittent or constant, because in cases of intermittent, you may observe for some time and the patient may have some fusion. And also you have to ask about glasses use, compliance, and recent changes, because sometimes the patient using wrongly prescribed glasses, which can cause the presence or the persistence of the exodeviation. Also, you have to ask about amblyopia and patches use. And lastly, you have to ask about sudden large deviation after surgery, which indicate a slippage of the muscle. Limitation of eye movement. These are very important in the history and also in the examination. This is one of my patients who had slippage after middle rectus resection. The exotropia was around 30 before surgery, and after surgery it increased to 50. And this is clearly showing the limitation. This is after the slipped muscle retrieval, the adduction become full. Again, in the examination, general observation is important. Head posture. If the patient has head posture, you have to suspect other condition like Duane cases. Facial asymmetry, fixation preference in regard of vision assessment. Visual acuity to check for amblyopia and fixation dominance. This is a patient with a Duane. You see, after you adjust the head immediately, patient have the exotropia. Also in the examination, ocular alignment is very important. Measure the angle at near and distance. Extraocular motility to check for limitation of abduction, which may indicate over-recession or scarring. Limitation of adduction, which indicate middle rectus slippage. And incompetence. In the examination, also binocular function to assess for the need for another intervention or for dot stereo acuity. Psychological refraction is important. You can also use the slit lamp exam to check for previous surgery. This is in a patient after lateral rectus excision, and we can see the scleral thinning here, very obvious. Also fundus exam to check for torsion, retinal pathology. Finally, force reduction test is important to be performed before you proceed with the next intervention. Sometimes you need to go for exploration as a final solution to discover what was the previous surgery. This is patient with a slipped muscle, and you can see that the retrieval was achieved with the help of remaining suture, especially if slippage is suspected. And you have to exclude consecutive exotropia if the patient has no source of information and his previous surgery was very, very old. As we see, this is a patient with after middle rectus recession, and he has a significant scar over the middle rectus muscle insertion area. Especially if he has some suggestive signs like near more than distance, if he has conjunctival scar, or if old photo shows esotropia. Now, finally, we come to the management. The principle of management is depend on the size of the angle, type of initial surgery, if known, ocular motility status, limitation or restriction, number of muscle operated for exotropia, and sensory deviation differ from normal cases, because in sensory situation you cannot operate the normal eye sometimes, and appropriate refractive correction was given or not. Non-surgical management usually chosen in cases of small angle of residual exotropia or recurrent exotropia. Intermittent versus constant use of prism over minuses. These are non-surgical management. For the surgical options, reported surgical failure rate in general can reach up to 50% at 5 years. 20% to 60% of patients require reoperation, most commonly due to recurrence. So in reoperation exotropia, general principle, evaluate if slipped muscle, stretched scar, or adhesion before reoperation. If motility is normal, either you operate on a previously operated muscle or non-operated muscle. If motility is limited, operate always in previously operated muscle. For example, if lateral rectus is slipped, you have to, if medial rectus is slipped, you have to advance it. After bilateral lateral rectus muscle excision, the choice will be either medial rectus unilaterally or bilaterally, depending on the angle. Can I extend? Yeah, unilateral medial rectus for small angle, less than 25, to decrease, lower the risk of overcorrection. If more than 25, you can go for bilateral. After unilateral resection, you can go to the other eye, either lateral rectus resection alone or combined with medial rectus resection. Also, you have the option, but this lateral rectus re-resection or augmentation of lateral rectus resection, it should be reserved as a last resort. It can be used in cases of sensory deviation, cannot operate on the fellow eye. Finally, botulinum toxin injection option for sensory deviation operated on maximum number of muscles. For recurrent deviation after 2 previous strabismus surgery, you can offer the patient an intervention with Botox, even we know that has limited value in these cases. This is the end of my presentation. I would like to thank you for this opportunity.
Thank you, Dr. Saif. If you have questions, you can scan the QR code and write your questions. Now we'll leave you with Dr. Hashem Al Marzouki, who's the president of the Saudi Group of Pediatric Ophthalmology and Strabismus. Dr. Marzouki is an associate professor of pediatric ophthalmology and the dean of College of Medicine at King Saud bin Abdulaziz University for Health Sciences in Jeddah. Dr. Marzouki trained in McGill University and Children's Hospital in Los Angeles. He holds the Canadian and American Board of Ophthalmology certifications along with Master in Medical Education. Dr. Marzouki is currently practicing as a pediatric ophthalmologist and he's the head pediatric ophthalmology department at King Abdullah Specialized Hospital for Children in Jeddah. Welcome, Dr. Marzouki.
Thank you, Dr. Mohammed. It's a great pleasure to be here today and looking forward for a fruitful discussion. So our case was referred from the EOS as a case of ROP for continuing the care in Saudi Arabia. The patient was born at 32 weeks of gestation and his birth weight was 1.2 kilogram with IUGR, and he briefly had respiratory, required respiratory support and requiring CPAP, and currently later on he was in room air. Initial ROP screening showed that he has a stage 0 zone 2 in both eyes without plus disease. However, his condition was associated with a lot of comorbidities, including bone marrow failure, hydrocephalus, seizure disorder on medication, and developmental delay. This is the initial photos that were shared from the US, showing that at later stage he developed exudative retinal detachment or changes in the right eye and posterior severe ROP changes in the left eye. He also did OCT, showing in the right eye there is subretinal fluid and exudative detachment, and also fluorescein angiography. And based on that, he required injection and laser treatment in both eyes, which stabilized his condition. So before I proceed, what do you think the main differential diagnosis? So for the audience, number one differential is ROP, but what other differential diagnosis do you think? We should think about, for example, fever, familial exudative vitreoretinopathy. We should think about code disease. However, because of the systemic association, we should put something else in our mind. Just to summarize his details, so the patient initially had no ROP. Later on, he developed severe ROP, a posterior severe ROP in the left eye and exudative detachment in the right eye. And he required laser treatment and injection, which stabilized his condition. Then he was transferred to Saudi Arabia, where a diagnosis of Revesz syndrome based on genetic testing was done and confirmed. As a result, he received intravitreal injection and was supposed to have examined anesthesia for laser augmentation. However, because of his systemic problems, he wasn't stable for another procedure or examined anesthesia. And this is his fundus finding when he was during his course in our hospital. So what's Revesz syndrome? So Revesz syndrome is a genetic mutation that has ocular and systemic association. The ocular association are similar to ROP and fever syndrome. So they have the exudative retinopathy like fever, and also ROP changes like ROP. However, the key thing here that they have also systemic association, and the treatment of care is early laser, anti-VEGF, and if required, vitrectomy. So just a brief comparison with other diagnoses just to help us. How did we reach or think about Revesz syndrome? As we all know, ROP, even though it's the leading cause of peripheral avascular changes, however, the most important thing in the history is the premature gestational age and the low birth weights. However, the systemic association, it's related to the prematurity itself rather than the disease. In fever, sometimes it happened in full term or later on, or even in premature baby. However, they have no systemic association. And the hallmark is the exudative changes that we can see with the disease. Revesz syndrome, usually it presents in term baby, sometimes in early childhood. And the key feature here, they have bone marrow failure. It's one of the major or the most important systemic association with this disease. They have other association, and the treatment, of course, is multidisciplinary approach. So what's the take-home message here? ROP is the leading cause of peripheral avascular. However, it's not the only cause or not the only one. You should think about other causes, especially in atypical cases. The key of making diagnosis and confirming the diagnosis was genetic testing. That's why multidisciplinary approach should be used here. So during the patient course in the hospital, the genetic department and precision medicine department were involved. The pediatric ophthalmologist and the retina specialist were involved also during this case. All this helped in the patient receiving the appropriate care. Also, the systemic association. As we said, in ROP, usually they have premature-related comorbidity, like intravitreal hemorrhage, for example. However, bone marrow failure, seizure disorder, all these systemic comorbidity conditions let you think about other diagnoses. Does it make a difference? The answer is yes, because then you shouldn't use the standard criteria for treatment. However, the early treatment here, including the laser and Avastin, might help the patient in addition to the systemic treatment and systemic care. Okay, thank you.
Thank you, Dr. Hisham, Dr. Hashem, and our colleague in the group. We have one question in the system here, then we'll open the floor for discussion. So the question is regarding my case. It is, would this management, which is the BCIOL implantation, still appropriate if the patient has macrospherophakia, any risk of complications regarding the IOL because of the zonulopathy? If there are signs of weak zonules, like phacodenesis, or the lens is macrospherophakic, then it should be removed. Otherwise, with time, it will increase the laxity and it may dislocate. In my patient, the diameter was good. It doesn't look to be microspherophakic. It's mainly spherophakia, and there is no phacogenesis. This was stable. This is why I choose to put the IOL in the back as long as it can accommodate the IOL. We'll open for discussion. دكتورة تفضلي.
Your case is a very nice case, doctor. It's very, very nice case. Actually أنا يعني الأول كنت فاكرة إنها حضرتك هتمشي في سكة ال ROP بس even ال first differential diagnosis العادية اللي إحنا متعودين عليها. أنا عندي بس حاجتين لأنه حقيقة أنا أول مرة أشوف presentation very nice. أنا investigative mainly. كنت أحب أشوف صور بتاعة posterior fundus بتاع two different المين different differential diagnoses اللي بينهم وبين ال ROP لأن كلنا متعودين على شكل ال ROP بالstages بتاعتها بس ال other two diseases دول مش كلنا متعودين إن إحنا نشوفها بالكاب. فكنت أحب أشوف posterior fundus بتاع الاثنين colored. حضرتك جبت كمان الاو سي تي كنت احب اشوف الاو سي تي بتاعهم عشان ابتدي احط بقى في دماغي ان there is another differential diagnosis of ROP اللي هم الاثنين دول يعني بالانفستيجيشنز بتاعتهم وبالذات سونار ساند التراساوند. تاني حاجه كنت احب برضو اسمع المانجمنت بتاع يعني واحنا بنتكلم على الار او بي كلنا عارفين المانجمنت ممكن يبقى انجكشنز وممكن يبقى حاجات تانية جديده بس كنت احب برضو اسمع المانجمنت مش عشان ده deficiency في البرزنتيشن بس عشان انا تلقيت معلومه جديده فايم فيري انترستد ان انا اسمع الحاجتين الجداد دول ايه عنهم even in short. وانا بتكلم على ده يبقى ممكن نتكلم على الحاجتين التانيين. ثالث حاجه كنت احب اعرف ايه في الباثولوجي الفاكتور المهم اللي مخلي الار او بي considered فاكتور مهم في حدوث الاثنين دول اللي ممكن يحصلوا في وجود الريتينوباثي اوف بريماتوريتي. رابع حاجه جيستيشنال ايج بتاع الار او بي كام اسبوع بالظبط ممكن يبقى له فاكتور في وجود التو ديزيزز دول لو هو الار او بي نفسها فاكتور. Thank you so much.
No, thank you very much for the questions. طبعا the first question اللي هو الصور unfortunately a major part of the course was in the EOS. So these pictures that were shared with us هي نفسها اللي we were able to show it here. يعني they didn't do a lot of pictures and they didn't share a lot of photos. But I agree with you. If it would be great if we also for us it will help us even in the clinical care if we had those photos. The other thing, the patient, as I mentioned, he's 32 weeks of gestation. So it's mentioned he's 32 weeks of gestation. However, with low birth weight. Yeah, it's in the table. It was mentioned in the table. However, يعني, the whole idea of presenting this case is to let us think it's not always ROP. It's just stimulate our thinking because unfortunately our mindset is anyone with peripheral avascular على طول بنروح إنه it's ROP. This is the take-home message here. It's not to present, of course, يعني it were many lectures and talks. Sometimes you have ROP session, that series of lectures to talk about all these things that you've mentioned. However, I agree with you. It's the whole idea here is to change our mindset. If it's atypical case, think about something else other than ROP. So first of all, here the patient is 32 weeks of gestation and 1.2 kilograms, so he's low risk for ROP. So to have these significant changes in a patient with low risk, it let us to start with to think about other diagnoses. Revesz syndrome, as we know, Coats disease and fever, they can happen in term and full term patients, not only in preterm patients. So we have to hold the whole picture to make sure or to let us think about other alternatives. تفضل.
بسم الله الرحمن الرحيم. محمد سامع الشربجي، أستاذ طب جراحة العيون وزميل جامعة لودفيج في ميونخ دويتشلاند. في سؤال بس دكتور إسماعيل بعد إذن حضرتك لما عملت ريبير للبيوبل في الايريدو داياليسيس أنا لاحظت إن طبعا اللينس الكورنيا borderline, it is not clear cornea. And the end of operation you inject air What's your opinion? It is better air or just BSS or saline?
Yeah, the cornea was clear. And
Borderline.
Yeah,
Cornea from the trauma.
But
Yes.
with follow-up, there was nothing indicating corneal procedure. And for air, I like to use air at the end of all my procedures in pediatrics for multiple reasons. First, I like it because it will work as a tamponade for the cornea.
Yes.
And second, if I do vitreous procedure, it will help me to decide if there is any vitreous, anything. Third, when I do see them post-op, sometimes it will be difficult for you to examine kids. But if I see the bubble, I'm happy. If I see it freely moving, I'm happy. So for multiple reasons, I like to use air at the end of procedure. Also, it will be like a space,
Yes.
potential space for IOP.
Actually, it is the air in the first, when it's big bubble, no problem. But the problem when the bubble becomes smaller. Smaller bubble can cause pupillary block if you cannot make an iridectomy, or the most dangerous, that there is this bubble rotate in the anterior chamber because there is a thermal current. The iris is hot and the cornea is cold, makes the bubble go and like that, it touching the corneal endothelial cells and they can cause injury to endothelial cells. This is a problem. The air bubble, when it is formed, no problem. But when it becomes smaller, this is a problem. Thanks.
Thank you. Okay, Dr. Ismail.
I have only comment for Dr. Saif, and I want to listen from audience about VEB. I think VEB in the first few months of life will not be conclusive. Only I think it will push you, not if you are not clinically happy to proceed with surgery, I think you are waiting for flat VEB, so it will push you not to do. But I don't think I'm depending on it clinically. If I feel clinically I will operate, I will operate. Even if the VEB is not responding. But I don't like to rely my clinical decision on VEB. Second, any corneal procedure, I will not proceed with it if there is high IOP. So no corneal procedure if the IOP is not controlled, except cataract. If there is cataract, I will remove it. But corneal procedure with no control of intraocular pressure shouldn't be done. Also, if there is surface disease, it shouldn't be done. If the other eye is okay and good, I will not try to operate on the cornea. I'll try to utilize his own cornea as much as I could, try to clear any visual pathway utilizing his own cornea. So for VEB, I feel we shouldn't rely much on it. If clinically you are not happy, you shouldn't say you will not operate if the VEB is flat or I will listen to you.
Of course, what you have mentioned is absolutely true. You have to depend on your clinical judgment, but the VEB is a last method of vision assessment in a non-verbal child who is clinically does not show any response or reaction. So in this situation where the clinical assessment and clinical evaluation showed no vision potential, you can go for VEB. And if the VEB is not recordable, it's an indication that the patient will not benefit. So it's not only a dependence on the VEB. And regarding the rest of the comments, I agree with you. And maybe that was a case report, and the decision, maybe it was not the appropriate decision.
And maybe Dr. Saif, does the laterality also make, because if the patient has bilateral, it's different when he has unilateral condition. Right?
Yeah, exactly.
Because if it's bilateral, you want to take the chance, even if you have a small chance, do you think? From visual outcome, I mean.
You mean the VEB use?
Yeah, in general, like when you have opaque cornea or sclerocornea bilateral.
Yeah.
Sometimes if
you would like to interfere to give some potential, potential of vision at least in one side. Yeah, but the main theme of or the aim of the topic is to evaluate the need for intervention based on visual evoked potential if you have no other clues.
Yes, sure.
We have one question here about the explanation of high IOP in the Spherophakia case that reduced after that. The lens is very shallow, so it's not pupillary block, or sometimes patient may have pupillary block, but it's like crowding in the angle of the eye. This what has released after removing the lens and retaining the AC depth to normal situation, and this is why the IOP get back to control. I don't think of BI because the AC was uniformly shallow. So just doing BI may not help the patient with this AC depth only of 1.4 millimeter. So there is any further questions?
I would like to thank you again for the generous invitation. We really, it's a great honor to be here today with you. Alhamdulillah. Thank you. And